So somebody wanted to know a little bit about torsional or rotary nystagmus, and it's uncommon to have primary position torsional nystagmus. So what we mean by torsion is rotation in the roll plane, and so the eye is going to be either moving in a clockwise or counterclockwise direction, and that is torsional nystagmus. Usually it's going to be bilateral and symmetric torsion. And the main thing about torsional nystagmus is if it's strictly torsional, that really means that it's a central problem, a central vestibular nystagmus, because the peripheral organ, the semicircular canals, are not aligned in the position to just do the roll plane. Horizontal nystagmus can appear in both peripheral and central, but in the peripheral horizontal nystagmus, it's unidirectional. So if we see purely upbeat or pure downbeat or purely torsional or rotary nystagmus, that really is a central problem. It doesn't tell you exactly where it is. It just means it's in the brainstem and in the central vestibular pathway somewhere. So you have to do an MRI scan regardless. But if the MR is negative, there are some things that you can't see. You can't see antibodies. You can't see paraneoplastic disease. You can't see vitamin deficiencies. And so you still have to do some testing for the usual suspects in terms of autoimmune, antibody, paraneoplastic etiologies. But most patients will have a structural abnormality if they have torsional nystagmus. The one that we most frequently see are patients who have a lateral medullary infarction. That's the Wallenberg syndrome. And so they often have a purely rotary torsional nystagmus. But it's rare for any of these syndromes to just have the nystagmus. They're identified by the company they keep. And so in the brainstem lesion, like the lateral medulla, there'll be crossed signs, face numb and body numb on the other side, and other lower cranial neuropathies that will be a giveaway that we have a medulla problem. And same in the midbrain or the pons. So any disruption in the central vestibular input can result in a rotary nystagmus. This purely torsional nystagmus is central. In the peripheral forms, where you have horizontal plus torsional and unidirectional, that's not what we mean by pure torsional. That has a horizontal component or a vertical component. Those could still be peripheral, and you should watch the video on peripheral versus central to tell the difference. Torsional nystagmus can also be associated with a eye that's rising and intorting and an eye that's falling and extorting, and that is a special type of torsional nystagmus called the seesaw nystagmus. That one does localize in the paracellar third ventricular area like pituitary adenoma. So you should be looking for the torsional nystagmus, tell whether it's clockwise or counterclockwise, and you're going to image the brainstem.